Your body just made a sound it was never meant to make. A loud, gruesome crack. The kind that instantly turns your stomach into a cold puddle. Your arm, leg, or ankle is bent the way it's not supposed to bend. And the icing on the cake is that. It's the end of the world. No hospitals, no surgeons, no morphine drip. It's just you and a very real possibility of losing a limb. Let's try to prevent that. First, you have to answer one question fast. Is it a dislocation, a fracture, or an open fracture? A dislocation means the joint is out of place, like the shoulder ball popped out of the socket. It often looks wrong in a very specific way, like the joint lost its normal shape and the person can't move it without pain that feels electric. A fracture means the bone itself is cracked or broken. It can look normal at first and still be fractured. An open fracture means the broken bone is sticking out of his skin and it looks like a horror prop. First, let's talk dislocations, because people love to treat them like a party trick. Dislocations are the ones where everyone's friend suddenly becomes an orthopedic doctor because they watched one clip online. A real dislocation can pinch nerves, tear ligaments, damage blood vessels, and sometimes it comes with a fracture on top that you can't often see. If you yank on it wrong, you can turn a temporary problem into permanent nerve damage. So here's a more sane approach. If it's a dislocated shoulder, elbow, knee, ankle, finger, whatever, check circulation and sensation below it. If the hand or foot is numb, cold, or turning colors, that means there is no blood circulation, which is bad. Especially if the joint looks shattered or if you heard a crack and there's tenderness along the bones and the limb is wildly unstable. That's most probably a dislocation with a fracture and you shouldn't attempt reduction, you will make things worse. Also, it's better not to mess around with a neck and spine. At that point, you immobilize in the position found, reduce swelling, and pray. If the dislocation is peripheral and the bones are visibly intact, you can try a reduction. Sometimes reduction is the difference between saving circulation in a limb or losing it entirely. You apply gentle, steady traction in line with the affected limb and guide it back toward normal position. If it slides back with a clunk and pain improves, you immobilize it, buddy tape it to the body, and keep it protected. For a shoulder dislocation, it gets more complicated and more risky because nerve and blood vessel injury is a real thing. The concept is not snap that sucker back into place, it's more of a let the muscles relax and allow the joint to return to normal position. If you ever try it, you do it slowly, steadily, and patiently. You stop if numbness spikes or you get resistance like you're pulling on a stuck door. If you manage to pull it off, pun intended, you immobilize immediately because the joint is unstable and loves to pop back out. Now let's move on to fractures. A fracture and collapse is extra scary for one main reason. Mobility equals survival. A broken arm is bad, a broken leg is catastrophic. But before we panic and start writing goodbye letters, we need to figure out what type of fracture we are working with. There is two main parameters that determine the type of fracture. First, whether it isn't displaced or stable, and second, if it's open or closed. Closed fractures are safer in terms of infection because the skin is still doing its job as a protective barrier for your flesh. If the limb still looks mostly normal, no weird angles, no twisting or shortening, no obvious that's not where that bone should be pointing shape, things are not too bad. That brings us to the first and least terrible option, the stable closed fracture. Here's how you assess it. First, take a breath and do a quick scan for deformity. Compare left and right sides. Does one look shorter, rotated, or strangely shaped? Then check for point tenderness, meaning pain at one specific spot on the bone. Press gently along the bone and stop if you find the, yep, that's it, pain point. Next, check function carefully. Can they move it at all? Are the fingers or toes warm and pink? Can they feel them? If yes, that's a stable closed fracture. These types of fractures are pretty liberating and can heal on their own, often without complications. But you need to splint it. The idea is to immobilize the joint above and below the suspected fracture if you can. If it's the forearm, stabilize wrist and elbow. If it's the lower leg, stabilize ankle and knee. Use anything rigid, boards, sticks, a broom handle, thick cardboard, a folded magazine. Pat it with cloth because you're not trying to create a pressure sore, you're just trying to immobilize the limb. Secure it, snug but not tight, and then immediately recheck circulation and sensation. Swelling can turn your perfect splint into an accidental tourniquet, so watch out for that. If you have pain meds, use them, but don't get high like an idiot. The goal is to control pain enough to function, not I'm gonna do a backflip right now, because that's how people worsen the fracture, feeling like they are fine after popping an oxycodone. Now let's move into displaced, closed fractures, the ones that make you cringe. The limb might be bent, shortened, rotated, or shaped like it was designed by an artist who suck at anatomy. This is where people get tempted to set the bone. And I get it. Your brain screams, dude, put it back straight. But here's the problem. The bone ends are sharp, and around them are nerves and vessels that you really, really need. If you crank on a displaced fracture, you can tear arteries, sever nerves, and turn a survivable injury into permanent disability. So the default rule in collapse is do not attempt to realign a displaced fracture unless circulation is clearly compromised and you have no other options. And even then, it's gentle and minimal. Don't yank on it like a monkey. Next, same idea as the previous one. Splint, immobilize, and pray that you won't lose the sensitivity in the limb forever and hope it fuses back into something that resembles the original shape. Also, watch for the signs of shock. Keep the person warm, calm, and as still as possible. Seeing your shin bone at a 90-degree sharp angle is not the most wholesome moment, you know. Now the juicy one, displaced open fractures. You have a deformity plus a wound plus high infection risk. Here, you absolutely prioritize bleeding control and wound coverage. Again, do not reduce it unless circulation is failing and you have no other option. If there is major bleeding, you control it immediately with direct pressure using clean cloth, gauze, anything you have. If blood is pumping out, you don't politely dab it like you're cleaning a wine spill. You press hard and you don't let go. You hold pressure, add more layers if it soaks through, and keep it steady. If the bleeding is life-threatening, bright red, squirting, and you truly can't control it, that's when a tourniquet comes into play, and that's last-ditch territory. At that point, the risk of losing a limb skyrockets, and your kid's dream of becoming a pirate with a wooden leg suddenly gets very real, very fast. You place it above the wound, on the limb, not on a joint, and not directly over the fracture site if you can avoid it. You want it on a single bone area if possible, like the upper arm or the thigh, because joints and weird anatomy make it less effective. Tighten until the bleeding stops. And if one tourniquet doesn't do the job, you apply a second one above the first. All right, you are not bleeding to death no more. That's progress. You do not keep loosening it to check. That's not checking. That's restarting bleeding and washing out clots. Once it's on and it's working, you treat it like a locked door. You leave it alone unless you have a clearly safer option and the bleeding is truly controlled by other means. And in a collapse scenario, your safest assumption is you will not have that luxury, so start preparing yourself mentally for a main role in a Saw movie. I know, it's brutal, but we are trying to survive in here, right? Next, you treat the open displaced fracture like the infection bomb. You cover the wound with the cleanest dressing you can, and you protect it from dirt, hands, and anyone who wants to take a look. Do not push bone back in. Do not dig around. Do not scrub deep in the wound. If you can gently flush visible dirt with clean water without destabilizing the limb, fine, but your priority right now is stabilize and evacuate, not doing a full surgical washout in an abandoned parking lot. Even with a tourniquet on, you still splint, because movement keeps shredding tissue and can restart bleeding above or around the injury. Keep the wound covered, change dressings when they're soaked or filthy, keep hands off it. Watch for infection signs like fever, spreading redness, heat, foul smell, pus, red streaks, worsening pain and confusion. That's your warning siren. You need broad spectrum antibiotics, and you need them as soon as possible. After, all that is left is keeping the person warm, hydrated, and fed, because the immune system runs on fuel. Protein matters for healing, calories matter, sleep matters. In collapse, sleep is hard, but your body repairs when you rest. All right, boys and girls, time for a quick recap. First, identify what it is: dislocation, fracture, or open fracture. Dislocation lives at the joint and looks like the joint shape is wrong and movement is blocked. Fracture hurts along the bone, swells, bruises, and may deform. Open fracture, this one is obvious, has a piece of bone sticking out of the skin. Second, check below the injury, check if it's warm, pink, if sensitivity is present. Third, stabilize immediately, immobilize, splint, sling, don't keep moving it. Fourth, if it's a dislocation, gentle reduction is the move, if there are no fracture signs. Fifth, If it's a closed fracture, splint above and below, manage swelling, treat shock. Sixth, if it's an open fracture, control bleeding, apply tourniquet if needed, cover and protect, irrigate gently if you can, splint, and then obsess over infection prevention because that's what kills later. Stay alive, my friends, and may your bones always remain in one piece.